Hi everyone, thank you for joining our virtual dental shadower session. We want to remind you that in order to get your hours, you will have to take a short quiz, and as long as you get a 3 out of 5, you will earn your hours. The quiz link will be located in our link tree, which is in our Instagram bio. All right, so let's get started. We're very fortunate to have Dr. Khan for today's session. I'm handing the mic over to you now. Feel free to start whenever you want.
All right. Hi, everybody. My name is Dr. Adil Khan. Just want to do a quick introduction of myself. I'm originally from Dallas and recently moved down to Fort Lauderdale, Florida. And I took over an office for Affordable Dentures and Implants, and that's where I've been working for the last year. I graduated with a bachelor's in science with a minor in chemistry from UT Arlington in Texas. Went to Lake Erie College of Osteopathic Medicine in Bradenton, Florida, where I did my dental school. And then graduated, went back to Dallas, worked there for a few years, and then made my way back down to Florida. A lot of folks ask me why I moved to Florida, why I left Texas, things like that. And realistically, it was really the dental school experience was really nice. I went to LECOM Bradenton, and being close to the beach, the Florida weather was awesome. So when we moved back to Texas, it was like, well, let's find a way to go back. And that's how I ended up here. So one of the things that I think a lot of folks want to, get dialed in on, especially like coming into dental school, is how to study, how to stay motivated. So these are some things that I did for myself. And I noticed worked for me and also my colleagues in school and even my brothers. So I have two brothers. One's just graduated dental school a couple of weeks ago. So congratulations to him and all the new grads. And I have another one at Baylor Dental in Texas. He is a second year. So, I get this question a lot from my brothers, and I give you guys the same advice I'd give my family. And it's, you got to just treat it like a sport, treat it like an athlete with their sport. Going with the mentality that it's you versus the exam. You have to own it. You have to walk in confident, knowing that you know your stuff, and you walk out confident. Regardless if you don't maybe necessarily feel like that on every exam. So what really worked for me was creating a system and sticking to that system so it's consistent. So obviously it takes a little bit of practice. It takes time and it takes dedication to kind of dial in on what works for you, what doesn't work for you. So there's a little bit of testing involved with that. But realistically, if you've done undergrad and you've gotten good grades, or you've been successful, you know what things work for you, what don't. Some people can study in groups. Some people need to study by themselves in a quiet room. Some people can listen to music. Some people need to take breaks. You have to do what works for you, realistically. But it takes being mindful of like, hey, what will work for me in the long term, and realizing that something, if it isn't working for you, you got to stop that and try something different. What worked for me was trying to put myself in the head of the examiner, right? Every professor, whether it be in undergrad or in dental school or anybody in life, you kind of got to think about what are they trying to gain by giving that exam? What are they trying to get you to learn? So you kind of got to get in their head a little bit. And if you can do that, you can start to think about how you would design an exam that would meet their criteria. And then when you start to read and learn, you're like, oh, well, that sounds like a concept that they would want me to learn, right? Let's say if it's about, I don't know, we're looking at dental anatomy, right? Well, a common fact is that the central incisor has the longest crown in the mouth, and some people might pass over that, but that stands out to me. It's like, that's unique. It's the longest crown in the mouth, whereas the longest root in the mouth is a canine, specifically the maxillary canine. So, those things stand out to me when I'm reading, about all the dental anatomy, which is a ton of facts. So those are, turns out those are common board questions. What is the longest root, in the mouth? What has the longest crown in the mouth? That sometimes I try to confuse you with that. And so those are the things you kind of got to try to use your head when you're reading. So not just reading things and memorizing or writing them down, but start to think critically when you're reading and studying. So that way you can kind of, filter out the noise, sometimes the unnecessary facts or the facts that are really, really, minute. You gotta filter all the minutia out and get into the detailed stuff that what's going to realistically be on this exam, what might be in a board exam, those kinds of things, because especially in dental school, a lot of what they want you to learn is typically concepts that are on the boards. So realistically, dental school wants you to pass the boards. It's really conducive to their stats if a lot of their students are passing the board. So again, try to think critically. Why are you taking these exams? Yes, they want you to know it, but they also want you to pass the boards. They also want to have good statistics for their so they can market themselves. And then you guys also know your field when you graduate. So it can sometimes be daunting. Dental school, especially the first few years, are very tough. But if you think critically, you can really filter out all the minutia and really stay focused. And again, treat it like a sport. Make sure you get good nutrition. You're getting good at sleep. I found that stretching helps a lot. Sometimes taking a little break, taking a walk in the sun. Because a lot of times we're sitting in the rooms and you're not getting any fresh air. So I found that my brain works a lot better when I've take a break, maybe go some fresh air, maybe go take a walk. It's really nice. So you got to do what works for you. But once you found your system, try to focus on that and hone it and get better at it. And it's really nice because exams are a great way to test you, right? So that like, hey, if I did really good on that exam, whatever I did to study for it worked. Hey, I didn't do so well on that exam, maybe I needed to switch it up a little bit. So take the time to really think critically about how you study and where your body and mind is in relation to that, because it's a system, right? It's all together. It's not like your brain is over here and your nutrition's over here and your sleeping is really crappy, and that's not going to affect any of the other stuff that's going on. So it's all connected. And again, treat it very be very mindful of that, because when you get out of dental school and you start to see patients, it's the same thing. I'm using my brain a lot every single day. So I make sure to get sleep, make sure that I get lots of rest before coming into a day at the office, seeing patients. And I'm making sure that I'm learning from each success and failure, just like you would on an exam, right? So none of that ever changes. So make sure, the things you learn now will obviously definitely affect you in the future in more ways than you know. But that's really it for that. That's what really worked for me. As far as community service, I'm a big philanthropist. I really believe a lot in community service. I think it's extremely important. I'm so glad that dental schools, appreciate that, even coming out of undergrad. So I've always been a part of it. I've done Florida Mission of Mercy. Before that, when Katrina hit, I was down there building homes with Habitat for Humanity. I've always spent my time as much as I can in service to others. When I graduated dental school, I did a big trip with a mission with an organization down into Haiti for 10 days. I was with them, seeing the orphanage, seeing the children there doing exams, and turns out that village specifically hadn't seen a dentist in over 7 years. So I also saw the villagers. It was a really amazing experience. It really gives you an appreciation for what we have, what skills we have. Not anybody can do what we can do, and I was the only dentist there, so there's definitely a huge need. And I'm a believer in God, and I think it's a God-given skill. And for me, it was a very religious experience in the sense of, like, I was able to help people with my own two hands. And I think it's an amazing thing, whether or not you're religious or not. I think it's an incredible profession that we have. And I think that sometimes you lose sight of that when you're 300 pages into a book that you have an exam that's due the next day, or whether you're like me, that's working a ton and sometimes seeing a ton of patients all day every day. It gets to be a little bit wearisome. But when you go out and do stuff for free, when you do stuff for other people's without asking anything in return, that's what I feel like I've done the most for my soul. So I really urge everybody to spend the time. If you're an undergrad, do it. When you're in dental school, try to volunteer for as much as you can, and especially do it when you graduate, because once you're out in the real world, you find that life, being an adult, paying bills and trying to just work a 9 to 5 and do the best for your patients and just be everything that you can be, all catches up to you, and sometimes you need to get some perspective. Going to Haiti was amazing because, like, United States is an amazing country. Haiti is only a short plane ride away, and it's terrible to say this, but it's less than the third world country. I mean, and especially right now, it's in very, very rough shape. And when you take a tooth out and you ask the patient, hey, post-operatively, make sure you get some ice on there, and the interpreter is looking at you like, hey, these people don't even have drinking water, much less ice. It's a very sobering thought, So again, I think it's really important for all of us to keep perspective and appreciate how much we have in our lives. So definitely do as much community service as you possibly can. There's hundreds of groups out there, and it doesn't have to be a big trip anywhere. You can do this in your own backyard, So I do free dental days in my community, and now that COVID is obviously it's a big issue, obviously in the community, but there's a huge lack of dental care in every community. So reach out to anybody that's doing it already to help them, or once you get out, can do that yourself. Make sure you stay on top of it. But hopefully in the future, if you guys follow me on my page, I will be doing more mission trips here now that travel is getting a little bit more easier. And looking forward to doing that for folks. So definitely dive into that as much as you can. Specialties, I'm a general dentist. So for me, it was a tough decision coming out of school, whether or not to go back for a specialty, whether I wanted to go back and just do general dentistry. I didn't quite know when I graduated what I really felt like I wanted to do long-term. I think there's a lot of folks, but then there's some people out there that like, hey, I know I love to do prosthetics, or I love seeing children, so I want to be a pediatric dentist. That's great. That's awesome. Good for you. But if you're kind of in my boat where you're kind of like not sure, and there's a lot of information out there you're not really sure about, for me, it was a simple decision. It was like, what is your return on investment, right? You're going to go in and invest another couple of years for a residency. What is the return on that? Is it going to be easier for me to get a job afterwards? Is my financial stuff that's come into play? Is my financial situation going to be better if I did a specialty versus not? What are the extra factors such as family and other things that come into play? Where you're living, typically that's usually difficult with specialties. Sometimes you don't get to choose where you want to live. And so there's a lot of things that come into play. I think now, especially with COVID and the lack of direct patient care that students are getting in dental school, I think it's a no-brainer, to be honest. I think a GPR or an AGD is a great addition to dental school, because you definitely want to know what you're doing. You definitely want to be able to come out of dental school and hopefully a specialty with some really, really good live patient experience under your belt, so that way you can do the best for your patients. When I graduated, it wasn't so bad. I had a lot of experience doing a wide array of work, and so I felt pretty comfortable coming out of dental school. And since dental school, I've invested thousands of dollars and hundreds of hours of CE to continue to learn and grow my skill set. So whether you go my route and do general and then come out and continue investing in yourself, or you go the residency route, I don't think either option is bad. I think it's a great problem to have. You can choose both, right? General dentistry is unique in that you don't have to necessarily specialize. So I think it's an amazing thing. And I have friends that love doing all aspects of dentistry. I myself really enjoy surgery and prosthetics, and that's what I really focus on. But everybody has to kind of make their own decision and look at your return on investment. That's the best way to look at it, I think, for weigh your pros and cons. Personally, I have thought about going back for a periodontal specialty, but then again, I with where I'm going, I'm not really sure yet. So we'll see what happens. But definitely, if I had to do it, I'd go back and get a periodontal surgical residency, just so I can honestly dive into surgery even more. But I do enjoy prosthetics. It's really fun giving people their smile back. And I think that's where we dive into dental case. So this is number one. In my patient base, I work for Affordable Dentures here in Fort Lauderdale. And, most of my patients are, ASA 1, mostly ASA 2, some ASA 3. ASA, if you guys don't remember, is like a medical classification for, where they are in their disease state. If you're a regular Joe Schmo, super healthy, not doing anything, basically if you're 18 years old, typically that's your ASA 1. Anybody above that usually is an ASA 2. That's somebody that has a managed disease. So let's say if they they have hypertension. So if they're managed and they're controlled, then they're an ASA 2. If they're diabetic and their A1C is less than 7 and they're controlled, then they're an ASA 2. But if you start to get into patients that are not controlled, let's say their blood pressure is really high all the time, they're non-compliant with their medications. They're not seeing a physician for their daily, for their follow-up care. Their A1C is super high and their sugars run in the hundreds. Then they're an ASA 3. So for me, most of my patients being an ASA 2, I have to know my medications. I have to know my interactions. I have to know my anesthetic limits. I have to know when to do treatment and when not to do treatment. So this is a patient that came to me. He had an upper denture that was all loose all the time. He couldn't taste his food. He was tired of the glue. So I offered him a solution that had implants. Now he is on a statin, which is for hyperlipidemia, to control his triglycerides, which is controlled. He was on a pressor, so for his high blood pressure, it was controlled. He was on metformin, so maintaining his diabetes type 2 with an oral medication, not on insulin or anything like that, not on renal failure, not on dialysis. So again, this is all controlled disease, and his A1C is less than 7. Typically, when you think about diabetes, you have to think about wound healing, right? So if you know anything about diabetes, you understand that wound healing, osteoclastic activity is all affected. So what happens when you do dental implants? You need that osteoblastic activity to help the mandible or the maxilla, all that bone to grow into the implant, to let it integrate, so that way it has a good long-term outcome. Now, with elevated sugars, you don't get that osteoblastic activity. It's inhibited as well as wound healing. So you have a lot of post-op complications. And implant failures is typically very high. So we have a cutoff, a general cutoff that we go by is an A1C less than 7. Now, an A1C is like your 3-month marker. So your sugars are going to be better for your everyday management. Hey, you check your sugar if it's 100, 110, 150, 120, 100, 180, right? That's a daily sugar. Your A1C is going to be a better long-term marker. So that's something I commonly ask my patients for. If you have diabetes, you've got to know your A1C, or we're going to order one from your physician, so that way we can know going into the surgery, we have all our T's crossed and I's dotted. I'm very commonly requesting records from their patients' physicians, making sure to get consents on and keeping them, managing these patients from a team approach. It's really important to understand that it's you as a dentist are working alongside the patient's physician, the patient's nurses, their home care, their caretaker, and you want to work together so that way you're getting all the information to give that patient the best outcome that you can possibly do. So that's why it's really important that you know your medicine, you know what you're doing. You are a doctor at the end of the day, so you got to know what you're doing. And so this patient was on metformin. He had a well-managed diabetes, so it was not something I had to be too concerned about. Things for him that I was considering before we did the treatment plan. He's a dentureless, obviously. I was looking at bone quality, bone volume. Where am I going to place these implants? What kind of AP spread am I going to have? You're going to learn all this down the road in dental school. I'm looking at his vertical dimension. If he's somebody that has a collapsed vertical dimension, which you typically have with dentureless patients, am I going to be able to open his vertical up? Am I going to be able to show a nice aesthetic smile? Am I going to be able to restore an occlusion that is harmonious for the patient's TMJ? So there's a lot of considerations that go in to designing a case. Without getting too much in the weeds here, there's definitely each of these is its own subject. So, but it's really fun for me to be able to start to learn, even when I'm doing a consult, be able to start looking at the patient's vertical dimension, looking at their lip line, making sure I can see how much, where am I going to design that smile for them, right at the console, watching the patient talk, enunciate, things like that. So there's obviously a lot of hard data that goes into it, but you also got to have a good eye for it. You got to be able to eyeball somebody and be like, I know where I'm going to put teeth, So that's where we kind of dive in here. So with him, he had a lot of good bone volume, and he had a very low length hanging alveolus. So for him, we did a lot of reduction to bring it up. So for him, you got to remember when you smile, you don't want to see the edge of the denture. So we wanted that transition to be below the lip line, and we treatment planned him for 4 implants and a fixed denture. So here I flapped his gums. I did a little butterfly on the palate to tuck away his gums, so that way when I'm working and with reducing that bone, my burr is not hitting the palatal tissue. And on the left hand side, or maybe your right hand side, I don't know if it's mirror or not, but on the right hand side, you see the post reduction, just kind of flattened everything out, took away some of the humps and the bumps. The next picture is going to be the implants. These are in. I thought it was a cool photo to take while they were still kind of hanging out of the bone. But these typically, once you've placed them, they will get flush with the bone. You want to place them flush, so that way they all the threads are covered and the bone has good contact. Implant to bone contact is really important. And implant selection and designing the cases are all really important things. So if you guys notice, the posterior implants are angled. I do this so that way I get a better AP spread and better force distribution of the maxillary denture when he's in occlusion and he's biting and chewing. So this is a concept called all on four. I do a lot of these. Palomalo came out with this in Brazil. And he did a lot of studies on this, thousands of cases, and he came up with this concept all on four. So if you guys are interested, I'm happy to answer questions about it later, or you guys can do some research on your own. But amazing stuff out of Brazil, and has really changed the face of dentistry. This is amazing that we're able to offer, same day teeth in a day. This is what this is. So we're taking whether they're teeth out, whether we're taking the patient's teeth out and doing, brand new smile, or somebody like him who already has had their teeth taken out and we're now building a new smile from scratch. So really cool stuff. On the right hand side isn't the shot. And obviously I skipped a bunch of steps there, but the implants are in. The denture is attached and it's finished off, and you can see that it's his lip is in the right picture. You can see that his lip is if I had let it go, it would fall right on the denture. Nobody smiles like that, so I'm not worried about showing that transition line. The midline's in a good spot. He's good sized teeth for this guy's face, nice and big. It's a big guy, big teeth. It's a really nice outcome, and this guy was extremely happy. My patients love these things, and so he's gonna go tell a ton of other people about how great his smile was. And that's the post-op radiograph. So there we can see we did a little bit of alveoplasty, so we flattened all the bumps. Implants are in, and they engage the floor of the nose. That's typically where I like to engage, and so all these implants are torqued to 50 Newton meters plus. That means they're not going to move on me. And so that's why we can load the denture the same day. So within 3.5, 4 hours, this guy's walking out with teeth that are locked in, that he's able to brush and smile with and eat with. And there's no palate, which is a big thing because there's no glue. This denture's not coming out. Like I said, it's a life-changing thing for most people. Here's another case. So for her, amazing patient, really, really nice. Was always self-conscious about her smile. You can see from the picture on the right, very gummy smile. She's not even really smiling there. That's just her biting down, believe it or not. So when she smiles, you even see more gum line. So she had a lot of periodontal disease, a lot of loose teeth and hopeless teeth that she wanted to take out, especially in the upper. So the treatment plan included maxillary extractions with a fixed hybrid and an implant bridge on the lower that we'll do, the next visit. But what you're going to see is on the top, again, considerations. When she's talking to me, I see an anterior open bite. That's her biting on her posterior. So she has an open bite on the anterior, a very gummy smile, a very high smile line. She's female. So again, this is typical for females to have a very high smile line. So already while we're sitting there at the console, I'm looking at these things. I'm thinking, wow, I'm going to have to do a lot of reduction of the bone to get that transition line up above her lip line, so that when she smiles and gives me a big ha 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 smile, you're not seeing that. And this is a very tough case from a prosthetic standpoint. Surgically, a slam dunk. So any surgeon will look at this and think, wow, tons of bone. I got nothing to worry about. I'm gonna put these implants in, we're done. But from a prosthetic standpoint, which again is what these people are here for, they're not here for implants, they're here for their teeth. You have to think, I have to make sure that this denture is not this fixed denture is not an aesthetic failure. And an aesthetic failure would be seeing that transition line when she smiles. So controlled medications, well-controlled ASA2, relatively healthy patient. But the big challenge for her was not so much where the implants are going to go, which is typically what happens, but really how am I going to design the final prosthesis? And starting with the end in mind is super key when you're doing these kinds of cases. You have to think from a prosthetic standpoint. So it's really fun for me because I do both. So typically, if you're an oral surgeon, you're going to do one. You're only going to work on the implant side, or maybe if you're a prosthodontist, you're only going to work on the prosthetic side. I get to do both in my office, so it's a lot of fun seeing these cases go from start to finish. Same thing you see from a lateral angle. You see that she's got quite a bit of, very bulky, big, large teeth, and then from the occlusal, you see again a lot of a very high palate, so and a narrow arch. So these are all things you got to think about when you're designing the final prosthesis. Did a lot of alveoli. So if you notice, the sockets for those teeth are almost obliterated in some areas. So that tells you that it did a lot of bone volume reduction. Again, looking at it from the anterior, you see that a lot of bone volume was taken away. If you look at the palatal tissue is just hanging. I mean, that's almost 5 to 7 millimeters that we took up. And that's it kind of goes it goes against a lot of what we're taught in dental school. We think that we have to save every little bit of bone, every single tooth has to be saved. But a lot of the patients that come to me are here for a different reason. They have tried traditional dentistry, or they're scared of traditional dentistry, and they've gotten to the point now where things are either failing, or they're done spending money on them, or they're at the end of the road. So that's when they come see me. And that's what you see with a lot of what I do now. And implants are in. You see multi-units are attached. So multi-units, so if you notice, again, on that x-ray that I showed you in the past, things are being placed at angles, right? So we got to fix those angles so that we have a path of drop, right? We got to come out in one direction. So for her, that's what the multi-units are. Multi-units that go on top of the implant, and they correct the angle so that way we have one path of emergence. And there, everything is sutured up, grafted, sutured up. Again, we had to do some tissue management to make sure that we didn't have a bunch of loose, flabby tissue, so we can approximate everything properly. And on the right-hand side, you see that the finished prosthesis. This is just a temporary, so imagine what the final is going to look like. It came out really nice. If you look at the access holes to the implants, close to the occlusal or lingual portion of the teeth. It's exactly what you want. This is awesome. It was a great case. That's why I love to take pictures. And this was a really nice one that came out, beautiful, and the patient was super happy with. And again, on the right hand side, you see that the intaglio surface of the denture is nice and convex. This helps with food. You don't want food getting caught underneath this thing, so they can water pick underneath it. And that went down, and she walked out of there. Unfortunately, I did not get a post pic, but she will be back, and I will take some photos and update. But that's a good pre and post X-ray. You can see from the bone, like just looking at how much reduction I did for the alveoplasty. You can see I did quite a bit, and I had a great result. Beautiful. Here's another cool shot. So I use a lot of CBCT. I'm doing a lot of 3D planning. So everything I do is plan 3D in the CBCT, and then I try to follow as closely as I can the plan. It's a lot of fun. And actually, I don't know if you guys saw my story. If you didn't, go check it out on my page. Just had a robot company stop by, and I'll get more into that a little bit later. But that's the next level for dental. I think dental implants. It's gonna be really cool. Here's another common case that comes through my office. Someone that's made some poor lifestyle choices. Maybe they were smoking, maybe they had drugs, maybe they didn't have access to dental care. We never try to prejudge anybody, especially when a young person comes through. They could have had bad genes. They could have had, they could have been immigrants coming from a different country where nobody really teaches dental care. So you always have to start with, empathy with every patient, but especially somebody that's young. You got to start with empathy. You cannot prejudge people coming into the office, because as soon as you do that, it really sullies what you're really trying to do, and that's supposed to be helping people. So I try my best to not prejudge anybody that comes in the door. When you look at this guy, he's a tattoo artist. You're thinking, he's a really bad drug user and meth head, and he's got the meth mouth, and you think all these things, right? But when you get to start talking to him, you understand that he, grew up in a very rural area, no access to fluoridated water. So he was drinking well water, no dental care, grew up drinking like Mountain Dews and sodas and stuff, never brushing his teeth. So he had a little bit of everything going on. Maybe he did some drugs he didn't admit to, who knows? But from everything that he told me, it sounded like this guy just had a tough life, and now he's trying to get himself straight, and he sees customers, and he's very self-conscious about smiling towards his tattoo customers. So he came to see me. Obviously very nervous. I've been the first dentist he's seen maybe in years and years. So I wanted to do the best for him. And being a younger person, especially losing all your teeth at a very young age, you know, as once you take teeth out, your bone volume starts to disappear as you age. So your body's amazing. It knows that teeth aren't there anymore, so it starts to dissolve. You have osteoclastic activity, so it starts to dissolve all the bone in the alveolus, and you start to get a lot of shrinkage. So that's when you start seeing a lot of collapsed verticals. Now for him, he was lucky enough to have some family members pitch in and get him better treatment plans. So for him, we did full mouth extractions, and you'll see why in a second. I'll show you the pictures. And we chose to socket graft everything on the top. So grafted everything on the maxillary to hopefully in the future do implants. And on the mandible, we were able to do 5 implants for a snap-in overdenture, something that clicks in, that's secure, and that he can actually function and chew with and smile with. So, but things we had to consider, with him, making sure that he was a smoker, so we had to talk to him about smoking. We had to look at his bone quality on the 3D X-ray, making sure that he had the bone volume that we needed to be able to place implants predictably. And we had to talk about post-op healing before we even started, because I knew somebody like him that's not used to taking care of himself, especially his mouth, will have a tough time with implants. We'll have a tough time with even just healing up. So we wanted to make sure that we had covered all these things before we start. That's really, really important. People don't like surprises. I don't like surprises. And so the last thing you want to do is do all this work and then have a big post-operative infection that lands the patient in the emergency room. And now you're getting calls from the oral surgeon in the emergency room, but hey, how do you want to manage this patient? That's a scary time. So, again, all about doing your due diligence up front and treating the patient in a whole way. So again, really, really bad caries down to the gum line, big infection, periapical infections everywhere. You can see in the posterior, he's had those roots have been like that for years, in the back. So he's been really just functioning like this for years and years, and just, never smiled. He came in and told me that, he's thankful for the mask, believe it or not, because it's given him a chance to not be self-conscious. So somebody like him, your heart goes out to him, regardless of whatever's going on in his life, your heart goes out to him. He's a younger guy. I can relate with him and I want to help him. So, we chose to discount some of his treatment and get him back on track. And that's what we did. So let's see, next photo, we dentulated his maxillary arch. We went ahead and grafted it and sutured it up. And so that's what you see there. And so that's what that's going to do is we're just, keep that bone in place, give it a good solid platform for the denture to sit on, but also in the future, leave some bone volume in case we want to do some implants, maybe build them a fixed hybrid or something like that. So on the bottom, we did some alveoplasty, took down some of the infected bone, took all that out. And that's what you see. It's all flattened out there. And next photo is some implants. So those look real nice, all placed very vertical in the same path of draw. Believe it or not, I actually lost one of the implants here. Let's see if I can point to it. I don't know if you guys can see this, but this implant in the number 22 position, he had a very large infection there. And I curetted, cleaned all these things out, as you always want to do when you're placing implants, preparing the bone for these things. But he ended up losing that implant down the road because it just, just had a really large infection and the bone just didn't want to heal properly. And of course, he might have still been smoking. So regardless, we placed 5, we got 4, and we're still going to have a good outcome. So I'm happy with that. And on the right-hand side, you see that it is sutured up. That's typically what you want to see. The tissue is well approximated. You don't want to see any bleeding spots because those are places where wounds can dehiss. If the wounds pull apart, then you get infection and you get all kinds of badness. So we want to try to avoid all that. After we did all this work, the last thing you want to do is have an infection. So that's why we take a lot of time to suture properly. It's a lot of fun, especially when you're in dental school, you're suturing on bananas and stuff like that. So, take the time to learn your suturing because it does come in handy in the future, especially if you're doing surgical cases. Let's see. Geez, that went quick. What time is it? I don't know. Nice. That was 30 minutes. We knocked that out really quick. I open it up to any questions if anybody's got any. I hope you guys enjoyed my presentation. I know it was a lot of stuff, probably some stuff that maybe you hadn't seen before. So, please follow me on my Instagram. Reach out to me through my email if you have questions. Happy to help. And ready for questions if you guys are.
So we do have a couple of questions. And for our first question, we have I know you have a lot of experience with surgery and prosthetics. Would you ever specialize in the future?
Yeah, I definitely would. I would think about it. Again, it's tough when you come out of school and you're a general and you kind of have had a chance. I've done a lot of endo. I've done a lot of cosmetic dentistry. I've actually worked with a lot of children as well, and I've enjoyed every aspect of dentistry. So being able to be in this role right now, where I feel like I do a lot of oral surgery and prosthetics. This is awesome. So is it possible I get tired of this? Maybe. But I think in a year or two I'll know a little bit more about where I want to end up long term. So yeah, I think it's definitely on the table. 100%. I've actually Nova Dental School is not too far from me. They have a great residency program that I've heard good things about. So I'm keeping that door open in the future for sure.
The next question is, would you recommend some volunteering organizations for international students?
International students, it'd be tough because I don't know of any international friendly organizations. I will tell you this. Google's your best friend. If you can get in touch with any sort of organization, whether you're an international or domestic student, if you reach out to anybody, they will all put you to work. You know what I mean? It's not going to be hard. You tell somebody that let's say if you're, I'm Pakistani by descent. So somebody in Pakistan wants to reach out to some organization and they're willing to, either if you're flying out to another location or you want to do something locally, like nobody's ever going to turn down free help. I'll tell you that. And if you come in with some good energy and are willing to put, you put your money where your mouth is and do some hard work, they'll make it work. So, and if you're in the United States and you're an international student, there's tons of organizations to reach out. I can list some specific. I don't know off the top of my head. I forget the one that I went to Haiti with, but definitely do a little bit of homework, take some ownership, do it. Reach out to some groups. But I know that anybody will take some help. So definitely look into that. I will reach out to some folks, and if I can, I'll post it on my page or some, the virtual dental page if possible. So yeah.
And for our next question is there a difference in which anesthetic to use if a patient is ASA2 versus ASA3?
Yeah, that's a great question actually. So I actually saw this today. ASA3, what does that mean? Somebody that's not controlled. So I had a patient today that was hypertensive, and he had a tooth that was bothering him, and his pressure would not come down. He was in my office for almost an hour, trying to just chill and wait, and kept taking pressure. So if, let's say, for some reason I absolutely had to take this tooth out, I would use something without epi. So epinephrine is a vasoconstrictor, and so a vasoconstrictor will obviously constrict the veins and vessels in the local area that we put them in, but can also travel in the bloodstream and cause your overall global blood pressure to raise. So we're taught not to use anything with epi when we have an ASA3 hypertensive patient. In his case, I decided to just call him back another day because he wasn't in excruciating pain, and I can get him managed with some antibiotics for now. But if I absolutely had to do it, I would have done it with carbocaine or prilocaine, something that does not have epinephrine in it to take care of his case. Now, it's different if you're talking, ASA is a general classification. You could have just somebody that's unmanaged diabetes. You could have somebody that's, unmanaged, lung cancer. I mean, it could be tons of things, right? So you have to, again, do your due diligence and make sure that the patient that you're seeing, you're not going to do any harm to. So the last thing you want to have somebody come in your chair and be, coming for a toothache. And I told the same thing to the patient. I don't want you coming in here with a toothache and walking out or getting wheeled out on a stretcher. So you never want to do harm, right? Do no harm is really, really important. So, anesthetic is one thing, but, everything that we do in dentistry has an effect. So you got to make sure that, any medication that you prescribe, you got to make sure there's no allergies, anything you give in the operatory as far as anesthetic, you got to make sure that, you're using the right things. So, yeah, absolutely. There's different protocols, let's put it that way. And you have to be very aware of those protocols. And obviously this doesn't happen overnight. I myself had made some missteps in my career so far. There was some things that I was doing that I had to refine as far as even anesthetic. So currently I use buffered anesthetic, which is closer to the pH of the human body. So it's less painful when it goes in, it comes on quicker, and it leaves quicker. So it's better for the body. So they use that now. And that again took a year or two to figure out, hey, this is something I need to bring into the office. So again, it's not going to happen overnight. It's a lot of getting educated, whether that be through specialty programs or through CE programs like I did. So it's good questions. Keep asking those questions for sure.
The next question is, what is the hardest part of working with physician offices?
The hardest thing is just getting the information, really. Like, most physicians are happy to assist me. I think they appreciate the fact that I'm putting their patients' care at the highest level of importance. So they appreciate when I reach out to them and ask them, hey, is there something I need to know as far as your patient that's being managed with your care, under your care? I really haven't ran into too many issues. But then again, there's always that one person that reaches out back to you and kind of throws the ball back in your court. And that, again, just elevates you as a practitioner. I had one patient's doctor, patient had a heart stent, was on blood thinners. I had requested a recommendation from the physician to, hey, what would you recommend me do as far as the patient's blood thinners? Do you want me to take them off? Do you want me to leave them on for the surgery that I wanted to do? And the patient's doctor reached back out to me and said, hey, you figure it out. You're the doctor. You're doing the surgery, And it's a little frustrating because I didn't prescribe the medication, but at the same time, it elevated my care in the sense of, okay, well, let me understand what I'm really doing here. Am I doing something so invasive that I need to have the patient off their blood thinners, or should I leave them on their blood thinners because I see that the risk is higher for them to be taken off than for what I'm doing? So again, by not doing harm, if I took the patient, if I had to take a couple teeth out and I can stop the bleeding with some gauze versus me taking them off the blood thinner and then they have a major stroke, you got to weigh that. How does that work? So again, it's for the most part, as long as you are, as long as you try, I think most physician offices will try back, and they see that you're trying and you're not just punting towards them. You guys are working as a team. But again, it just sometimes getting in touch with doctors' offices is a little bit tough. They're busy. I'm busy. Sometimes faxes don't meet each other, and ball gets dropped. But I think for the most part, it's not too bad.
And the next question is, I saw your story today about robots and implants. That looked super interesting. Can you explain more about what was happening and the expected benefits?
Yeah, so I'm glad you brought that up because I actually forgot. I had mentioned it earlier. So I'm big on toys, right? Like everybody, who's not, right? Especially as a dentist, you're gonna learn that you're gonna be big on toys. Everybody wants the latest, greatest thing. Like I'm looking at digital dentistry, I'm looking at 3D printers, I'm looking at robots. So that's a really cool one. I mean, I sat in that bus and I was like, jaw on the floor, like this is not real life. Like pinch me. Like how crazy is this? That like in this day and age, we got a freaking robot that can like place implants. That device is it's meant, so it's really cool. So we take a CBCT and we plan the case digitally in the X-ray, right? The 3D X-ray. It transports to the machine, and basically it's now guided. So like it literally you can only place the implant in the right position, exactly where you planned it on the X-ray. You cannot, you literally have to, you can't even push the robot. Like it gets easier as you go towards the site that you had planned, and it gets harder the further you try to push away from it. So it's literally like a guide. It's like literally guiding your hand in to exactly where you need to go and putting the implant exactly where you planned it on the X-ray, which is precise. That's as precise as we get. I think it's going to change the face of dentistry, honestly, especially with implant dentistry. Like, I do hundreds of implants, so for me, the things that I'm looking at for benefits is obviously speed, precision, and having the medical legal, having that plan that I can put behind me and say, yes, I planned this out. It went exactly as planned. There's a video, because when you get into this kind of dentistry, there's obviously the medical legal standpoint that has to be perfect. But I think for the person that's, coming in, maybe doing like 10, 20 implants a year, and now jumping into an office where they have this, I think it's amazing because it takes a lot of the guesswork out. Like you have something to help guide you. And I wouldn't call it training wheels. I really think it's more of an aid in aiding you to be better. And even me, like, to have better precision. There's plenty of times when I'll place an implant and put a pin in there and I'm like, man, I don't know, I don't like that angle. And I reposition it. And thankfully, most times that works great. Every now and then it doesn't work so great. That's just part of the game. But with this, you have the precision of getting that implant exactly where you had planned it, and it's really incredible. And so when you talk about implants and positioning, you have to think, well, what does it matter, right? What if it matter if an implant's just a 2 or 3 degrees off, or lingual or buccal? What does it make a difference, right? As long as it's stable. Well, if you go back to what we had just talked about earlier, it's all prosthetically driven. So if I have a crown, we want that crown, the access hole of the implant, to come right through the center of the occlusal. You don't want the implant to be here and you have an access hole coming out of the buccal, where you can see it. That would be terrible. I've seen a lot of that, unfortunately. So when you have prosthetically driven dentistry, especially implant dentistry, then it becomes really important to have high precision. Now, guides, they have guides that help you drill the osteotomies. Those are complicated. They're expensive. You have to order them beforehand. You can't do same-day dentistry with that kind of stuff. But with a robot, it's like you can program it. You can walk into your operatory and you can place the implant within 30 minutes. You're in and out. You can do it flapless. A lot of you guys saw I fillet the gums all the way out of the way. I'm down to the bone, so I can visualize everything. With this, you don't have to even do that. I mean, you can think about the pain that's involved as far as healing. It's minimal, right? Because you're just poking a little hole, putting the implant in, and the gums will grow over really quick. You're not doing this big flap. So there's just amazing benefits coming out of modern technology as it enters dentistry. And I'm so excited to be in a field where there's constantly new things coming out. If you ask 5 years ago, even, is there going to be a place for 3D printing in dentistry? Well, today people are buying desktop printers and printing dentures, and they're bleaching trays and even clear aligners, like Invisalign, competitors for Invisalign. People are printing those off right there on the tray, like in the room. Dental guides, retainers, all kinds of stuff. So I think the next step is going to be robots. And so I'm very excited to possibly work with this company, Yomi, to bring robotics into my office. So you never know, guys. You might see some cool stuff on the page coming here shortly.
Oh, that sounds really cool.
Yeah.
So the next question is, can you give us a basic explanation on what an all-on-4 is?
Yeah. So let's do this real quick. So the whole reason we have all-on-4 is we want to do same-day dentistry, right? We're able to take people's teeth out, put implants in, take the denture, screw down to the implants, and you're walking out with teeth in a day. That's the whole concept, right? So to do that, we need to have, we need to be able to load the implants, right? We want to be able to have so much support of the implants that we can attach a denture. What happens when implants don't have support? What happens when they don't torque properly into the bone? Well, you get movement. And the way implants work is that the initial placement of the implant has to be really tight. If it's not really tight, you have a little bit of micro movement. If you get micro movement, you're not going to get osteoblasts growing into the implant. You get I forget the name of the word, but anyway, you get tissue form around the implant. So now you're not integrating into bone, but you're having soft tissue grow around the implant, and the implant's failed. So that's a complete failure. So what Palomalo found out is that, let me just do this real quick. I'm going to draw. So check it out. You guys can see this. This is the nose, the floor of the nose, the sinuses right here, the frontal sinuses, and the alveolus right there. So what he found out is that by tilting the implants so that they run adjacent to the frontal sinus, he found that he was able to have place a longer screw with fatter threads so that it could grip the bone tighter and reduce the amount of denture hanging in the back versus straight implants, right? That's part of his concept. But the second part of the concept, which is the most important one, is that he's placing the implants in a way that they go in very tight and there's no movement. And by taking the denture and attaching it the same day, now you're attaching all 4 implants together. There's no movement. There's no micro movement. Otherwise, the whole thing is moving, which is very unlikely. So you gain a lot of stability by tying all these implants together. So from a surgical standpoint, you have 4 implants going in. They're being placed in a very tight fashion. So they're high initial torque. And then from a prosthetic standpoint, all these implants the same day or within 24 hours, the denture is getting attached and locked in. And now you have the all-on-4 concept. So with that, you get long-term success, 98, 99% success of immediately loaded implants. Typically, historically in the past, everybody that used to place implants, what we would do is typically place the implant, let the gums grow over it, let it heal for 6 months, then uncover the implant, then do all the work above the gums. So then start to attach dentures and things like that. So, that's a really long treatment plan. So, you might start somebody in January, you won't finish them until like December of that year. You know what I mean? It's a whole process. And in the meantime, they're wearing a loose fitting denture that has a pallet, they're using glue, it's miserable, everybody hates you, you're terrible to the patient. But in this situation, you skip all that. You basically in one day, in like 3.5, 4 hours, if you're quick, you take the teeth out, implants are in, you take a denture, you screw it in, and then, patients walk out with teeth and they don't have a pallet, they don't have any glue, everything is stable, and all you're doing is unscrewing that temporary and screwing in the final at the end of the day. It's 4 screws. So it's an amazing, amazing concept, but it all started with Palomalo and this treatment protocol that he developed. Again, it's 4 implants, 2 in the anterior, engaging the nasal floor, then 2 like this to spread out the implant load, right, from the occlusion, and then attach it all the same day. So that's, again, I'm really dumbing it down. There's a lot more that goes into it, but that's a good, I think, intro to all-on-4. And what's really cool is that because of social media nowadays, a lot of this is coming out and people love seeing these before and afters, and it's really getting out. And so, I think you'll see a lot more of this going forward. And hopefully there's a big place for robots in the future with this, because it helps.
And our next question is, in dental case 1, did the patient have the surgery and dental in the same day?
Yeah, so he's an all-on-4 concept. So for same thing. So for him, I took teeth out. I'm sorry, it wasn't even teeth. He had teeth done prior, like years and years ago. So he came to me because he hated his denture. And, with the palate being covered, you have a lot of taste sensors that are gone. The roof of your mouth has a lot of taste receptors. So he came to me, miserable. So what I did is I offered him a solution, and that's the all-on-4 concept, placing the implants, in his case, no teeth. So placing the implants and attaching his denture the same day.
And for the next question is, for someone with unmanaged health conditions, is there a point where it is better to give them a bridge versus an implant?
Yeah, there's 100%. There's still room for bridges. A lot of fixed prosthetics. Yeah, so 100%. There's always room for bridges in dentistry. If you have really, really bad diabetes, if you have, if you're worried about osteonecrosis, if you're undergoing like active radiation and chemotherapy, well, then is it a good idea for me to start filleting your gums open and drilling holes? No, like you don't want to get osteonecrosis, bone death. So yeah, in that case, 100%, a bridge is a great option. Sometimes from an aesthetic standpoint, if let's say a patient has a really high lip line and you need only a couple teeth to be replaced, am I going to like flap open everything and reduce all this bone? No, at that point, a bridge is a much better option. So there's always, but again, you have to, as a complete practitioner, know when is it right to do implants, when is it right to do bridges, when is it right to do root canals. To give the patient the best outcome, you got to understand all these concepts and why they're being done and what is the pros and cons of each, and then offer that to the patient like I do. I offer them, hey, I might not be the right person for you. I'm happy to tell that to patients, like maybe this is better served at a general dentist who does these treatments. I don't do them in my office, So I always put the onus back on the patient, but you have to educate them, but you got to be educated yourself first. So that's a great question. 100%. There's still a place for crown and bridge.
The next question is, how are temporary dentures different from permanent dentures?
Temporary dentures are typically like an eyeball. So they're an immediate denture. And once you kind of do more of these things, especially when you get to dental school, you kind of do more of these immediate dentures. You understand that it's made of like a temporary type of material. It's a little bit softer acrylic, typically softer teeth. It's just acrylic teeth. They're just meant to be something that gets the patient through the healing process. So in my case, whether they get implants or not, they're getting a temporary denture, and it's more of an economy denture. The reason being, again, we're going to be basically tossing that in the trash once we do the final denture. or use it as a spare, if it's a removable denture. But there's a lot of differences in the material and the quality of the denture, et cetera, et cetera. And nowadays with final, especially hybrid dentures, you have all kinds of choices: zirconia, crystal hybrids, nanoceramics. You can use titanium bar wrapped with acrylic. So there's a ton of options. So there's a lot of differences. Again, that's diving really deep into it. If you're really interested in that kind of stuff, definitely reach out. I'd love to go over it with you.
For the next question we have, for case 3, if I understand correctly, implants were placed on the bottom jaw only. Why were implants not placed on the top jaw?
Finances. So that's a big one that I have to deal with, especially being an affordable office. Not everybody can come in and drop 20, 30K on their teeth. It's just the reality, So you offer that patient the best thing you can. And in his case, I actually grafted his maxillary bone for free. I didn't even charge him because I knew this is something that I'm doing that he doesn't even understand fully yet. That's going to give him a huge, huge benefit in the future. Not everybody can afford. So the low hanging fruit is always the mandible. An upper denture can stay in with suction. The bottom denture does not stay in with anything. You don't have to use glue. It sits like on the mandible like a saddle, right? There's no suction from the lower denture. Your tongue is going to be constantly lifting that denture. Your cheeks are going to be pushing it all over the place. That thing just floats around. So if you think about it, you really, if you don't have anything locked in on the bottom, it's just your dentures are just going to just do this, and you might get some chewing action, but you might not. And most patients can't. So whenever a patient comes in, it's on a tight budget, I tell them start with the bottom denture. That's where your money is best spent. So that's why we started with the bottom for him.
And for the next question is, how many teeth can be pulled out in one appointment?
The short answer is all of them, to be honest. It's not uncommon for me to edentulate patients with 28 to 30 teeth. I typically don't mess with third molars because I don't feel like it, but even if they had to go, I would take them out. You can take anything you want out, really. Like that patient that you saw, case number 3, that's with implants. That's like a 3-hour procedure, for me, taking the top out, grafting it, suturing it, doing the bottom, implants in, suturing. I mean, that's with teeth taken out. We did it all in one appointment. So, for somebody that does this all day, it's not uncommon to see lots of extractions, So, but there's some patients that can't handle all at once. So you just do the top and then come back to the bottom. So it just depends on patient acceptance, and how confident you feel you're going to be able to take out. Because the last thing you want to do is tell a patient you're going to take all of them out, and then you're not confident in your skills, and you get stuck taking out one tooth, and you take 3 hours to take out one tooth. Then you can't just keep injecting patients with anesthetic. It's not going to work. So you obviously start slow, but if you're in my case where you're doing all this all day, every day, you tell the patient predictably, I can do this in 2.5 hours, 3 hours. Expect your ride to be here. I'm going to be in and out, and I got to move on to the next case.
Okay, so for the next question is, I apologize if I'm using the wrong vocab, but I recently learned that there are 2 ways of putting in an implant. Implant, abutment, then the crown, versus implant, crown, then the abutment. What is the difference between the 2?
I'm not exactly sure what you're asking, because typically it's done where I think you're kind of off on the terminology. Typically it's the implant, then you leave the implant alone. You bury it underneath the gums, let it grow over. Typically in the mandible, it takes about 4 to 6 months to heal. Maxilla, 6 months. Then you uncover it, so you take the gums off, and you put the abutment on, right? Now you're letting the gums grow around the abutment. And then last, you put the crown on. That's typically how the workflow is. Sometimes that abutment can be a healing abutment, or it can be a final abutment. That's where you kind of have some variation, but I think you're kind of off on the terminology, but it's always implant, some sort of abutment, and then the crown goes on top. Now, the crown also has an abutment inside of it. So again, it's confusing to think about it. You have to the terminology can kind of be a little bit overwhelming sometimes with implant dentistry. There's a lot of parts. My assistants still are trying to figure out, sometimes what is this and what is this, and then every implant system has its own, verbiage. So, I'm again happy to reach out to me if you want afterwards, and we can kind of figure out exactly what you were talking about. But typically it's implant, gets buried, then we uncover it, place the abutment, let it heal, remove the healing abutment, take an impression, send it to a laboratory, and they fabricate a tooth with an abutment inside of it, and that screws down onto the implant. That's typically what happens.
Okay, and for our last question, what's your favorite procedure to do?
Obviously implants. I love screwing things into people's heads. Like I tell folks, it's always a good day when I'm getting some if I'm got some bone and blood on me. But I really enjoy all on four because it's such a satisfying feeling. You're literally doing it in one day, and patients come in and they walk out and like, what the hell? This is amazing. Seeing that like wow factor at the end of the day, and after a long hard day, this is not a short easy procedure, and it takes a lot of precision. So to be able to knock out a really well done all on four with a nice prosthetic outcome is super satisfying, and that's honestly one of my favorite procedures. But then sometimes, one of those somebody comes in with a broken tooth, you take the tooth out, put an implant, you put a crown on top of it, and you're like, you're a hero again. So it always involves implants, but anything that gives me a good, satisfying smile at the end of the day is worth it for me.
So we actually have a follow-up question. What's your favorite tooth and why?
Favorite tooth? That's a good one. So favorite tooth to take out, to extract, is a maxillary third molar. It's like popping a pimple for me. It's so nice. Like the bone is really soft and mushy back there, and usually like they're hard because you can't see them. So it's almost like a blind procedure. You stick something back there and you kind of twist it and it just like pops out, and it's such a satisfying feeling. That's my favorite one to take out. And it's always funny because you look at the patient, you're like, hey, did you feel anything? And they're like, no. And then you take it out, and you're like, hey, check it out. It's already out. It's like 10 seconds. It's great. But favorite tooth in the mouth? Man, that's a tricky one. I never thought about this. I like the canines. I think the canines are always have been a really important tooth. When we're designing occlusion, when we're looking at aesthetics, we're looking at support for, like, let's say like a partial. The canine is like the strongest tooth we have in the mouth. It's got the longest roots, real thick, and it usually gives me those headaches too when I'm taking it out. So that's got to be probably one of my favorite ones. It just has a lot of there's a lot that goes on with the canines. Good question.
Okay, and that is it for the questions. Thank you, Dr. Khan, for taking the time to talk to us about your profession. It's truly appreciated, and I know I learned a lot from your presentation. And to our viewers, our quiz is linked in our link tree and in the description of this video. The quiz will stay open for 24 hours, after which it will close and the scores will be sent out. A 3 out of 5, again, is required to achieve credit for our session. To Dr. Khan, I want to thank you again for today. Everyone, have a great day.
Thanks, guys. Have a great rest of your evening.